Hi everyone, I'm Sanil Rege from Psych Scene. Welcome to this edition of Hub Bites. Today we have a very interesting guest, Professor David Nutt. Professor David Nutt is a researcher, policy advisor and author, and is currently head of Neuropsychopharmacology at Imperial College London and chair of the charity Drug Science. David uses brain imaging research to explore the effects of drugs in the brain and the mechanisms of disorders such as addiction and depression. Under his leadership, the Psychedelic Research Group at Imperial College has become one of the world's foremost psychedelic research laboratories, publishing landmark research on the neuroscience of psychedelics, and from these, developed new therapies for mental illness. Professor Nutt has also held many leadership positions in both UK and European academic, scientific, and clinical organizations, including presidencies of the European Brain Council, the British Neuroscience Association, the British Association of Psychopharmacology, and the European College of Neuropsychopharmacology. He was previously chair of the UK Advisory Council on the Misuse of Drugs. In 2013, he won the John Maddox Prize from Nature Sense about science for standing up for science, and in 2017, a Doctor of Laws on Causa from the University of Bath. A really great privilege to have you, Professor Nutt. Welcome. Looking forward to having this chat.
Thank you.
So, Professor Nutt, with the topic of psychedelics, I guess the big question, what are psychedelics?
Well, when we're talking about them in the context of psychiatry, we're largely talking about drugs such as psilocybin, magic mushroom juice, or DMT, which is generally now used as ayahuasca. These are serotonergic agonist drugs which produce quite the classical psychedelic states that reported famously, of course, under the influence of mescaline by Aldous Huxley in his book, The Doors of Perception. There's also some debate as to whether ketamine or S-ketamine, these glutamatergic antagonists, which are now being used for depression, are psychedelic. Certainly, they do produce changes in brain activity rather similar to the serotonergic drugs, but they're not subjectively quite the same. But it may be that they both work, in a sense, in the same way to have their clinical effects.
Right. So the word psychedelics and hallucinogens, are they sort of used interchangeably?
They often are, yes. So people often talk of the serotonergic hallucinogens like LSD or psilocybin or ayahuasca. Psychedelic was a term that was I think, developed by Huxley to explain the effect, which is mind revealing. And that in itself is a very interesting choice of words, Greek words, because that's kind of what we are using them for now. We're not using them for the hallucinations, which is often seen negative, although many people find them quite pleasant, particularly the visual hallucinations. But the purpose of using these drugs is to make changes in the way people understand themselves and to disrupt. When we use them clinically, we're trying to disrupt maladaptive patterns of behavior. And in fact, just I jumped the gun a bit, but when we're using psilocybin, as we've been doing now, we've done 2 trials of psilocybin for depression, resistant depression. And mind revealing is quite important because there are 2 elements to this. The first is that depressed people, when they go through the trip, they often see the reasons why they're depressed. For the first time in maybe ever, they've understood why they're depressed. So they can reveal the nature or some at least the factors which lead to depression. And of course, the other thing about them is that they can open the mind to new solutions. So people can think differently. People can sometimes come to terms with their abuser, for instance, in a trip and actually kind of get closure. So I prefer the term psychedelic to hallucinogenic.
Right. Now, LSD was initially, I think, sort of discovered in 1938, somewhere around there, and in the 1960s had a significant sort of focus, highlights, and I think Tim Leary, the Harvard professor, quite charismatic, talked about young people to sort of turn in and sort of drop out and go against convention. From what I understand, in the 1960s, there was this resurgence with lots of research papers, large number of trials, international conferences on psychedelics were present. The question, what happened afterwards?
Well, as with all great developments, politics got in the way. And it was the Vietnam War. These drugs were seen and were being a revolution in psychiatry and clinical neuroscience. And then the Vietnam War was going badly. Young Americans were opposing the war. People could be caught up at the age of 18, depending on whether their birthday ended in an odd or an even number. They could be sent to this country that they'd never heard of to fight an enemy they'd never see for a cause they didn't understand in a place that was disgustingly hot and full of mosquitoes. And they didn't, for the first few years, they went innocently thinking they were going to change the world. And then info came back, people came back, the bodies came back, the broken, the invalids came back. And the war, people started challenging the purpose of the war. It was not only destroying American men, but it was also destroying an awful lot of South Asian women and children as well. So the anti-war protests started, and some of the potential soldiers escaped to Canada, others went to San Francisco. LSD was becoming used now in more in art and in music. And LSD was seen as fueling the anti-war movement. Of course, it wasn't, but it was an excuse to get the drug banned. And so they were banned then, and they've been basically banned, and they're still banned now. There's no country in the world where LSD is a legal drug.
Interesting. So when you touched on briefly sort of the mechanism of action, but if we had to go a bit deeper, as psychiatrists, as mental health professionals, to understand in terms of receptors, how do psychedelics act? So
let's focus completely now on the clinically used ones, which are psilocybin, magic mushroom juice, and ayahuasca, which is DMT juice. So ayahuasca, just so everyone understands, DMT is a very short-acting serotonergic psychedelic. The effect lasts about 5 minutes. If you give it intravenously, if you take it, it doesn't work orally. So the only way to use it orally is in this combination called ayahuasca. And ayahuasca is a combination of a plant that has DMT in it and a plant that makes a monoamine oxidase inhibitor. So psychiatrists know about those, but this one's called harmaline. It's not a clinical one, but it comes out of a plant. So you drink a tea made of the two. The harmaline prevents the breakdown of the DMT in the liver and the gut, so the DMT from the stomach can go through into the brain. So DMT is a serotonergic psychedelic like psilocybin, and both of those now there are clinical trial data with both those drugs. So how do they work? Well, they stimulate their agonists at the 5-HT2A receptor. And that receptor is a very interesting receptor for humans and for psychiatry, because the human brain has more of those receptors than any other brain. Evolution in primates and in other species has shown that the human brain is particularly endowed with these 5-HT2A receptors. So what are they there for? Well, they're on neurons which control cross-cortical information. As you probably know, that the brain is essentially a collection of billions, 150 billion little computers, each called a pyramidal cell. And the first level processing of everything in the brain is done by these pyramidal cells in cortical columns. But then the connectivity, that pulling together things like seeing, hearing, thinking, that's done by these what called the layer 5 pyramidal cells. They integrate brain function to make the brain the amazing organ it is. And those cells are very well endowed with the 2A receptor. We don't know why. We have theories, and I'll come back to that later if you want. But they're very densely, the receptors are densely expressed on these layer 5 pyramidal cells. When you stimulate those receptors with, say, psilocybin, you dramatically change the function. In fact, you effectively disrupt cross-cortical communication. And that breaks down the ongoing patterns of neural activity, which are underpin everything we do. And that is why the psychedelic state is a very different state. That's why people feel differently. They often feel that their bodies are changing. They often feel that they're floating out into space. They often go to other universes or other dimensions, because the normal control of your brain is broken down. And it's in that state, when you disrupt typical classic, your traditional day by day, minute by minute ongoing thinking, that you can think differently. And that is the mind revealing aspect of the psychedelic.
Right. The 5-HT2A agonism, I'm just wondering, some of the antidepressants would have 5-HT2A agonistic activity. For example, when serotonergic drugs sort of increase serotonin and they activate it.
Yeah. Well, that's
is
very
there a
hard
similarity?
Well, the answer is actually not. Yeah, in theory, you'd expect that. You think, well, what if you took an overdose of an SSRI, say, or if you took, say, a combination of an SSRI and an M1 oxidase inhibitor, which I wouldn't recommend anyone doing, you get the serotonin syndrome. The problem with the serotonin syndrome, it isn't just a 2A receptor being stimulated. In fact, what we know with SSRIs, when you get unwanted effects of hyperstimulation of serotonin with SSRIs, that's probably more mediated through the 5-HT2C receptor, but it is possible that some elements of the efficacy of SSRIs is mediated through the 2A receptor, and this strangely is a problem for us. So let me just elaborate a bit on this. Psychedelics don't work in people who are on SSRIs.
Right.
The SSRIs desensitize the 5-HT2A receptor. Now, what we don't know is whether that's important in the therapeutic action of SSRIs. I'm not sure it is, but it might be. Because there is a theory that says, okay, great, you take your psilocybin, you have your mind expansion, you see the world differently, you come back, and then you kind of reframe your whole attitude to your mother or your abuser or whatever, and so you're not longer depressed. But so that's one explanation of the therapeutic benefit. But then the other, the more prosaic explanation from some neuroscientists, all you do is you just desensitize those 5-HT2A receptors, because if you stimulate them, they desensitize. So desensitization might be the end product of both the psilocybin and SSRIs. Now, that is a really interesting question. I think it's unlikely to be the case, unlikely that is the mechanism, because if that were true, just blocking the receptors would be equivalent to desensitization, and that would be antidepressant, and it's not. But it might have some benefit, because, for instance, one of the things we commonly do when we're using an SSRI and we're not getting a full response is we add in what people often call an atypical antipsychotic. But I think what we're doing there is we're adding in drugs which have 5-HT2A blocking properties.
Yeah.
So there is this interesting paradox about the 5-HT2A receptor. It's for many reasons, and I won't go into them today, but even at the molecular level, it's a very unusual receptor. So it is possible that some of the effects of SSRIs are mediated through that receptor as well.
And that's really, really fascinating, because the recent sort of article, in Cell, where they looked at, that antidepressants, ketamine included, probably work through a completely different receptor, the TRKB, the BDNF receptor. And the question is whether, is there any evidence that psychedelics, work through a
psychedelics
BDNF?
are very, absolutely, I think the reason that drugs like psychedelics produce enduring changes in people's view of themselves and the world is because they also do stimulate neuroplasticity. One of the key aspects of this 2A receptor is that it seems to control the activity of these pyramidal cells, and pyramidal cells activity is intimately related by the number of synaptic spines they have, the number of inputs they have, and there are other studies now recently showing that psychedelics, 2A agonists, LSD, psilocybin, do increase the growth of synaptic spines, probably through a BDF type process as well.
Coming to psilocybin, you have touched on psilocybin. What would be the current indications for psilocybin, the current landscape?
Well, it's interesting because so we now there are open trials in tobacco smoking, helping people quit. That's the Matt Johnson stuff from Johns Hopkins. There's an open trial by Michael Bugenschutz in helping maintain abstinence or reduce alcohol intake in alcoholism. There's our open trial in resistant depression and a very small trial in OCD. So there's four trials of psilocybin in 4 different disorders. Now you might say, well, what brings it in? How can it work in addiction and depression? And I think this is where the neuroscience is particularly exciting, because in each of these cases, almost certainly, it's the same disruptive process. So what does that tell us about the disorders? Well, these disorders the way I interpret these data is to say that these are all internalizing disorders. In depression, people are ruminating about past mistakes and failures and guilt. In addiction, people are ruminating about the tobacco or ruminating about the alcohol. In OCD, people are ruminating about cleanliness. So I think they're all internalizing disorders. They're all disorders that people resist. People don't want to be where they don't. These thoughts happen, but they can't stop them. And psychedelics disrupt them. And let me get one of perhaps the greatest insight that Huxley produced in Doors of Perception. He said, well, what happened? I took mescaline, he said, and my mind opened. And I understood things. My mind understood things it had never understood before. My mind was effectively released. And then he went on to make the logical conclusion. That means something is constraining my mind. What's that? Well, the only thing it can be is the brain. So he said the brain is an instrument for focusing the mind, and psychedelics break down that ability. And that's what we've shown in the brain scanning has actually shown that's what happens. And so in these different conditions, people's brains are dominating their minds. They're getting locked into thinking they don't want to be locked into. And we can just break down the brain, take away the brain's control, let the mind run free for a bit, and hopefully come up with a new solution, a new approach. It is quite remarkable. The tobacco data are really fascinating, because when you talk to Hopkins, and in fact, you can listen on the Drug Science website, you can listen to my podcast with him. And he says, when you talk to people who've given up smoking, it wasn't that they reduced their consumption. Basically, it was all or nothing. Like 3/4 of the people in that study, they never smoked again. They just said, smoking has no interest to me at all, like it has for most people who don't smoke. It kind of reframed them. It put them away from ever thinking about smoking. So it was a kind of completely remodeling their affiliation with what used to be the love object. So that's where we are at present. Now, what's happening? There have been 2 controlled trials in people with end of life anxiety and depression, both one from the Johns Hopkins group, one from the New York University group. They both showed that they help people reduce anxiety and depression, which obviously commonly occurs when people are told they're going to die. We've now completed, and it's going to be published hopefully next month, the first head-to-head of psilocybin versus escitalopram. And I think you're going to find those results very interesting. And I suppose in terms of the conventional drug development, Compass Pathways in America and Europe has set up a multi-center study of basically an efficacy, a sort of phase 3 efficacy study, where it is a sort of 2B/3. So where you have 3 doses, 1 milligram, which is placebo effectively, a 10 milligram, a midi dose, and a 25 milligram, which is a trip dose. And I'm really looking forward to those results, because I suspect they're going to show that 25 is very, very effective compared with 1, and 10 is probably going to have some effect, but not be significant.
Right. And I guess this fits in with the recent study, which I understand you were a part of, Robin Carhart-Harris as well, and on microdosing. And I think just a few days ago, where they attributed, I think the headline was very much about, the use of psychedelics being, or the benefits of psychedelics being due to placebo experience. Would you like to sort of expand on that aspect?
Sure. Well, so we did it was the lead author Balazs it was his brilliant vision. He worked out how we could do self-blinding. We were 4 years ago, we had ethical permission to do a microdosing study. So microdosing, for the listeners, microdosing is giving a sub-psychedelic dose. In fact, really it should be a sub-detectable dose, but some people do find they get some small sense of alteration of consciousness or mood with it. So it's a very low dose, and definitely a non-psychedelic dose. And you take it usually. There's a sort of regime, 3 or 4 days a week, and a few days off. So, but no one's ever studied. We had permission 4 years ago to do an LSD microdosing study, but the hospital and the ethics committee said every single microdose had to be given in hospital, and people had to stay in for a whole day because the half-life of LSD is like 6 hours. And that was just too expensive. We could not afford to do it because of the controls, the fact that this is a Schedule 1 drug. So we went out into the community and we asked people who were actually microdosing, and we gave them envelopes so they could randomize between placebo tabs and LSD tabs, and then we collected the data, and it turned out that about 90% of the effect of a microdose is what is expectation. It's placebo. Now, that's, to my mind, that's not that's fine if you feel better taking placebo. Well, the adverse effects are likely to be pretty low, so that's fine by me. But it encourages me in what we're doing, which is using bigger doses. It's single big doses to produce profound reframing of mental states. That's the way forward.
So when we think about microdosing, you mentioned the doses of psilocybin, sort of 1 milligram, 10 milligram, 25 milligram. Where would microdose fit in?
One.
One.
It would be between 1 and 3.
Right. Okay. So with regards to psilocybin, there is a study that you mentioned, sort of comparing psilocybin and escitalopram, that with the results due to come out. When do you think we might get to sort of have that?
Well, in a normal world, they'd be published already, but the top journals are basically it's 9 out of 10 papers in the top journals are COVID related. So it's being delayed by COVID, which is unfortunate, because actually I think there might be some utility for these drugs in some of the people who've been traumatized by COVID. But you know what journal editors are. They sit above God.
So yeah, I guess for anyone who's tried to publish, absolutely, I think it takes a long time. With LSD, DMT, and sort of mescaline, you did talk about ayahuasca as well. So do these differ in terms of mechanisms, or are there any sort of differences between the psilocybin aspects? Could psilocybin be interchangeably used with LSD, DMT, mescaline?
Question. Really important. They differ. Obviously, they differ in terms of potency. So it is really important that you understand the dose of what you're taking, because LSD is it's about 1,000 times more potent than mescaline. So you don't want to mess with that. Make sure you get a decimal point in the right place. That's the first thing. They all work through the 2A receptor, but they all have different interactions with other receptors, which is why some of them, so for instance, mescaline causes a lot of vomiting, whereas LSD doesn't. So we don't fully understand why that is. The key difference, though, is in terms of the half-life. And that's the reason, actually, one of the reasons we pioneered our research with psilocybin. You take it orally, it's a 3 to 4 hour trip. It's we know it's very safe. Millions and millions of people, youngsters in Britain, were using the mushrooms and for decades, and we know that there are no deaths, so we know it's very safe. And same with LSD, it's very safe. But an LSD trip lasts for 12 to 15 hours, which means for research purposes you have to keep people in hospital overnight, which means that triples the expense, and also for clinical practice that would triple the expense. So psilocybin is much shorter acting than LSD. But DMT is really short acting. So if in our scientific studies of DMT, we give it intravenously, and I think you can probably give it intramuscularly as well. So that's a shot, and people have a powerful transient trip which lasts about 10 to 15 minutes, and then they come back. So and there is a very interesting scientific question now. Some people are saying, well, that's all you need if you're going to just shake up the brain to get rid of depression. Maybe that's all you need. Just shake up the snow globe, and it'll all settle down in a different way. That may be true. I mean, if it is true, that's interesting. My own view is that it's probable that the longer trips, the 2 to 3 hour trips with psilocybin, are going to be more useful to depressed people, because basically it's not about shaking up the brain. It's about getting into the brain processes of depression while the brain is shaken up. And that's why we now call this therapy psychedelic psychotherapy, because everything we do is done with the ambition of the person coming out of the trip and then engaging in psychotherapy. And so I find this really exciting because this is bringing together sort of cutting edge psychopharmacology with the potential for innovation in psychotherapy. And I'm really keen that our two disciplines, which often are fighting each other, can actually come back, and start holding hands.
So when we think about psychedelic psychotherapy, what would a session actually look like? If I were to sort of, enter into session, what would the duration look like? What would the actual session look like?
So really important. Let me explain the process that we are using in our clinical trials. So, which is likely to be pretty similar to what ends up in clinical practice. And there are 4 key elements. The first is what we call the preparation session. So you have to explain to people what's going to go on in a trip, because most of them haven't had a trip. And you have to reassure them that even if they feel they're going mad, they're not, and that there will always be a therapist present, and help them work out how best to deal with what are often very negative experiences. Let me just dispel one myth. One of my senior colleagues said to me once, well, of course these people are getting over the depression, they're just having a fun trip. I said, the trip might have been fun for you when you were young, but for these depressed people who've been, often been traumatized and suffered for decades, the trip is not fun. It's a really hard thing to do. They're often reliving. They relive their trauma. It's hours of really difficult psychological experiences. It's not fun at all. And in the trip, we don't do any psychotherapy. We're there, we're present. If they need to talk, if they want to talk, if they want to have hands holding, if they're very frightened, we nurture them, comfort them, but we don't ever try to engage with them, because even in our volunteer studies, we had this, you'd say to them, okay, now it's 2 hours into your trip, will you please do this test? And one guy said, oh, fuck off, I'm talking to God, And the point is, when people they are beyond anything that's relevant, they don't care about whether you can serially subtract sevens.
Yeah.
It's a different dimension of consciousness. So we don't ever engage because we don't know what we're going to get back. But you could actually just destroy the person. Could be at the point of that insight and you destroy it. So we never. But after the trip, we obviously reassure them, and then the next day we have what's called an integration session. And that's where they talk through with their therapist. Usually we have 2, but maybe you could do it with 1. They talk through for several hours the experience. And then the therapist guides them to see what meaning there is in that, and what learnings there are, and what insights there have been. And then that process, in an ideal world, that would you'd continue then for, say, 6 or 8 weeks psychotherapy each week, looking at those issues and trying to then use other, whatever psychotherapeutic approach you're familiar or skilled at, to improve the long-term outcomes. In practice, for the clinical trials, we can't do that. But in clinical practice, I think we will be able to get even better outcomes by that long-term follow-up psychotherapy.
So for a typical sort of, I guess we have a session, and that session would last approximately how long through the entire trip? And then there is a post sort of session.
We do the integration the next day.
Right.
It's a good point. Do we need to do it the next day? Well, we do it then. So, it's quite a long day. But it may not need to be. So, what do you do? Well, if people come to the clinic, say at 9 or 9:30 in the morning, you prepare them, get everything ready for an hour. That's 10:30. They take the psilocybin. You have to budget at least 5 hours to make sure it's all gone. It's all through and everything's over. Then they might need to do a bit of talking down afterwards. So it is a day. It's a day in the. Right. So it's not like esketamine. Esketamine is a 2 to 3 hour experience. You can do that in half a day. This is one of the big challenges for this research, is that it's quite expensive. If you've got 2 therapists and you've got a clinic for a day, that's a lot of money. And that's one of the reasons some people are saying, well, DMT might be better. It might be, DMT is more like ketamine. You give them a quick blast and then they can go home an hour later. So there are economic arguments for having shorter acting drugs. That's one thing to say. But we always do the integration the next day. And that's just happened to be because it's easier in a day than it is to have everyone hanging around till late at night doing therapy. And also, I think people are often quite drained. 4 hours of sort of going through the traumas in your childhood can be emotionally draining. So we think people are better able to cope with the insights the next day.
And how many such
that would be a 2 to 3 hour session. You'd budget 2 hours generally.
Right. Generally, when we think about change, or I guess change in terms of monitoring, depressive symptoms, etc., how many trips are we looking at, which include preparation and integration? Is there sort of a number?
Well, the good news is you don't need to do much preparation for the second one, but
Yeah.
because they've been prepared the first time. So we've done 2 studies. I can only comment on our own work. We've done 2 studies. The first one was just a single trip. The second one was 2 trips, 3 weeks apart, the head-to-head with escitalopram. I can say that most of the benefit comes from the first trip.
Right.
Compass pathways are just using a single trip.
Right. So I guess...
Hang on, but let me wait. I want to qualify this, though. The immediate benefit comes. So with the second trip with the escitalopram comparison, it may be we got a floor effect. So the reason we did the second trip 3 weeks after the first was actually not necessarily to get a better outcome, because that's difficult when you've got a good outcome already, but to see if we could prolong the benefit. Right. That data, we're still collecting that data. We haven't got that data yet.
Sure. So I guess one potentially can consider psychedelics to have sort of enduring and possible permanent change with the single. I mean, we don't know that conclusively, but I guess there is potential for that.
Well, plenty of people. I mean, Steve Jobs famously said that that LSD allowed him to invent the biggest company the world had ever known, until Amazon, which is that's a pretty powerful drug effect. One of the many people who use these drugs for sort of self-awareness rather than therapeutically say they're one of the 5 most important experiences of their life, and that's what Steve Jobs said. So looking at our first depression study, so we now got data going out for like 5 years. And about 15, well, let's think, of the 20 patients, probably 4 are fully recovered. So 20% fully recovered. The rest have slipped back. Some have gone completely back to where they were before, and others have gone partially back. That's at one level disappointing, but at another level, well, the fact that they all got better after a single dose, and many of them have been ill for, well, the average was like 13 years. They'd all failed on many drugs. They'd all failed on CBT. And to my mind, it's disappointing, but not surprising. I mean, if you've spent the last 20 years ruminating about your worthlessness, your brain is a habit in the same way as smoking's a habit and OCD is a habit. You've downloaded, in a way, your consciousness to habit. Breaking that, the fact we can break it at all is amazing. And I think what we're looking now is if we could do, maybe repeated doses, maybe twice a year, in some kind of therapeutic setting. Like people might go away to a meditation retreat or a yoga retreat. Maybe you go away for a psychedelic retreat and try to reset your brain and then go back to work or whatever.
No. So when we're thinking about, we've talked quite a bit about the psychedelics, psilocybin, LSD, DMT, and fascinating stuff. MDMA. I remember, you talked about it when you'd come down to Australia 2 years ago, and you've previously talked about it as well. So MDMA, from my understanding, doesn't fit the description of a typical psychedelic, but is showing quite a lot of promise in psychiatry as well. Could you expand a bit on that?
Yes, please. As you probably know, last week we published our the first ever study of MDMA in alcohol use disorder. And we showed, again, an open trial, but 2 MDMA sessions, 125 milligrams, 2 weeks apart, as part of abstinence-based alcohol therapy, had an outcome which was infinitely better than our current therapeutic model. So with our current psychotherapy model, 80% relapse in 6 months. Just those 2 MDMA sessions just inserted into the therapeutic model, 20% relapse in 6 months. So this is a remarkable effect. And why did we do it? Well, we did it for the same reason, interestingly, as we did the psilocybin in depression. We did brain imaging studies. They showed what you pointed out already, that MDMA is not remotely like psychedelics. It doesn't change the cortical function the way a psychedelics does. But what it does do, very powerfully, is suppress the amygdala and the hippocampus. And we thought, that is why it's being used in PTSD, because I'm sure all the psychiatrists listening to this know that the current preferred therapy of PTSD, if it doesn't respond to SSRIs, the therapy is exposure therapy It's prolonged, effectively 2 or 3 hour exposure therapy, allowing the patient to exhaust the emotion so that you eventually, the emotional resurgence, which comes with the memory, eventually extinguishes, and so it no longer perturbs their life. But many people cannot sustain that. I started working on PTSD in 1989. The reason I did that, we started researching a new tool for continuous non-invasive blood pressure monitoring. That was a level of our ability to monitor things in those days. And we started putting PTSD patients through it, and we discovered extraordinary, instantaneous perturbations of blood pressure when they started to remember. And in those experiments, we found people, they would dissociate, they'd faint, or they'd just run out the room. You couldn't engage them in the therapy because the emotions just were so overwhelming, and they were physiologically destructive. So, fast forward 30 years, we can see that MDMA dampens down those reasons. So we thought, well, that explains why MDMA works in PTSD. And then Ben Sessa, who is a colleague of mine, who was a child psychiatrist, and then he got disillusioned with that and moved into adult addiction psychiatry. He always said, isn't it bizarre? I'm treating these abused kids and I'm loving them, and we're all nurturing them. As soon as they become adolescents, we put them in prison for being misbehaving. This is wrong. And he's right, it is wrong. Many, many alcoholics turn to alcohol to deal with trauma. So he said, well, look, why don't we deal with the trauma with MDMA, and maybe they'll stop drinking? And that was what we did, and it was remarkable. And now we're setting up a controlled trial to try to show that was a real MDMA effect, and not just a kind of a prolonged exposure effect under MDMA, independent of the MDMA.
Right. So MDMA PTSD is well known, but for those listeners and viewers that aren't aware of the effect, could you expand on what is the actual effect with PTSD in terms of efficacy?
Well, again, this goes back to the classic work of the Mithoffers. They've done 2 trials now, 2 controlled trials. You take people with PTSD. The first trial was resistant PTSD. They'd failed on at least SSRIs. They failed on CBT. They put them through a classical PTSD, psychotherapy program. I think theirs was 18 weeks, 18 sessions, talking about the trauma, helping them to reframe their life, etc., etc. But twice in the middle of those 18 weeks, they gave them a single dose, the same dose as us, 125 milligrams of MDMA. And during the trip, they made them relive the trauma so that the emotions started to come back. And they discovered that you could extinguish the emotions much better under MDMA. So that after the trip, they didn't have the flashbacks, they didn't have the conditioned emotional reflexes, which are the core problem of PTSD is not the fact you had your legs blown off. It's a fact that every time anyone makes a noise, bangs a door, you feel that you're being blown up again, and the emotions of that, you actually believe you're in the instant of the explosion again, and that is totally destructive to anyone's life. So extinguishing the emotional reflexes, extinguishing those unwanted perturbations of consciousness is the critical solution. You never forget the trauma, but you can at least suppress the emotions that damage you.
Right. So if we think about, there's lots of promising research. What's stopping this from sort of becoming mainstream?
Well, they're all these drugs, LSD, psilocybin, ayahuasca, and MDMA. They're all illegal in all Western countries. So this research has been enormously difficult. It costs 10 times what it would cost in a sane world to do this research because of all the constraints. I had to have a special safe to put my psilocybin with a camera, making sure that when I take it out, I don't slip it in my pocket. And I say to the regulators, well, why can't I just store it alongside the heroin I use for my other research? And they say, well, that's because heroin is a Schedule 2 drug and this is a Schedule 1 drug. And I say, look, the reason I'm storing it is to stop people stealing it. If anyone breaks in, they're going to steal the heroin, they're going to steal the psilocybin. Come on. But the regulations have created this kind of monstrosity of bureaucracy, which is, that's why virtually no one has done any research on these drugs for 50 years, because it's just too tedious and too difficult. And you've got to be, you got to anticipate living a long time and be bloody-minded like me to persevere with it. So we've got to try to change the rule. The regulations serve no purpose. They don't protect people against recreational use. All they do is deny access of patients to this therapy.
Right, yeah. So I guess the big question I'm sure everyone's thinking is, we've talked about the efficacy, clearly very, very promising research, side effects, adverse effects. So if we the traditional sort of psychedelic aspect is these experiences. Some of them sound like psychotic experiences. So the question is, what is the potential for adverse effects? And in your experience, what have you noticed?
So yes, I can answer that in two ways. I can answer that from my experience, which is we don't ever put anyone into these trials who has been psychotic or who has a first degree relative who is psychotic or has been psychotic. And therefore, we have seen no psychotic reactions. And we've seen, basically, when you see the paper that's coming out in a few months, you'll see, apart from the trip itself, there's a big debate. Is the experience of a trip an adverse effect or not? I mean, I kind of say, well, of course it's not, but then you could argue it, well, it might be. So anyway, we report those, but after the trip, there's no side effects at all. And that's one of the reasons many patients are looking for this therapy, because they don't want to be on a daily dose of something which might affect their sexual function or increase weight or something. But much better than my experience, we go back to history. We can go back to when these drugs were banned in the late 60s in the US and the UN. The psychiatrists were very upset because they'd done lots of work, and many psychiatrists thought these were revolutionary treatments. So there were analyses of thousands and thousands of treatments. And if you look at, remarkable, the rates of psychosis were lower than you predict from normal therapy. The rates of suicide were lower than you'd predict. And there were virtually no other adverse effects. So the evidence that these drugs are harmful when used in therapy very intermittently, maybe twice in a lifetime, the evidence of harm is not there.
Right. So generally so I'm just sort of thinking in the future, if, a psychiatrist were to prescribe sort of psychedelic psychotherapy at some point, as we do with, say, SSRIs or SNRIs, we generally advise them of the potential for, to take them regular, withdrawal, sexual dysfunction, akathisia, emotional blunting, etc., etc. So what would be the top 5 or 3 side effects that generally one would mention in psychedelic psychotherapy for patients that are undergoing therapy?
Oh no, it's only the experience. It's only the experience of the only anything that lasts beyond the experience are headaches. So quite a few people get headaches overnight and the next day. They're and actually that is quite an important point. Migraineurs may get worse headaches, but you can use these drugs to treat severe migraines like in cluster headaches. So there's a paradox here, and that's probably got something to do with this desensitization that I talked about before. But truly, the only adverse effect that endures beyond the trip is headaches. So you just warn people about that, and you can take a couple of paracetamol. Right.
I remember sort of seeing, and this is 1 or 2 patients, I remember as a registrar, individuals that were using recreational drugs quite a lot, particularly ecstasy, LSD, and magic mushrooms. And I remember these cases, 2 cases of persistent derealization, depersonalization. Is that something that is a potential risk, or?
Yeah, of course it's a potential risk. Absolutely, yeah. I mean, it is a potential risk. But I say everything is mitigated by the way we do it. But we know what we're doing. We know what dose we're giving. We've got therapists present. So, I mean, as you know, derealization, depersonalization often associated with anxiety disorders. In some ways they are an anxiety disorder. And that's why we say never, don't go out into the bush and take these drugs. We're looking at, this is medical therapy. It's like the same way as you say, well, you wouldn't encourage someone to go out in the bush and start taking opium to deal with their pain. We're looking at a therapy, a powerful therapy. Recreational use, I wouldn't encourage because of the potential harms. But that we shouldn't be banning. We shouldn't be trying to eliminate recreational use by banning medical use. That's all I would say.
Yeah. is there a risk, or do you foresee, or I guess, the governments, I wonder whether they sort of are particularly worried about this aspect, is it possible that the approval of psychedelics for medical purposes, is it possible that that actually leads to an increase in casual recreational use, because people go, well, it's for treatment, therefore, I guess we could use lots more of it. I wonder.
Well, all I can say, the best example we have where that hasn't happened is cannabis. Medical cannabis hasn't led to a recreational. Of course, there is a worse example, I suppose, which is previous medical use of opiates in America. But medical systems can predispose to problems. But cannabis and opiates are different from psychedelics because you take them every day. So there is a scope for diversion. No one is going to be taking home a psilocybin tablet. There won't be diversion. And that means it's very, very unlikely that there's going to be any slippage from medical prescribing into recreational use.
Yeah, that's a really, really good point. So psilocybin is administered as a tablet. LSD, how is that administered in trials? Well,
we injected it, but you can give it as a blotter on the tongue.
Right, and then DMT.
It used to be a tablet. No, all the research was done on LSD tablets, 25 microgram tablets. Yeah.
Okay, and then DMT you mentioned was intramuscular or intravenous.
DMT is very interesting. People are looking at intramuscular, they're looking at intravenous. Some are looking at a nasal application like esketamine.
Esketamine, interesting. Okay, so thank you so much for, I guess opening our minds to, and I guess dispelling a number of myths, because I guess the first thing that people think about psychedelics is somehow that those psychotic experiences or, the adverse reactions. Now, recreational drug users often talk about bad trips. So, and I guess individuals who are vulnerable and with depression. So I guess the question is that most of these patients are going to have bad trips, but these bad trips in the right setting actually lead to a potential transformational change.
Yes, talking about them as bad trips, and the point is, therapy is difficult, isn't it? Exposure therapy. The big problem, exposure therapy is brilliant for spiders, but most people won't do it because it's just too unpleasant. So the reality is that, powerful therapy can often be very challenging. So we don't call them bad trips, we call them challenging trips. And it's quite likely that if you don't master those challenges, you won't get better.
Right.
And actually, that's an interesting problem, Sanil, just to share with you our OCD trial. So we're setting up an OCD trial. But the patients, they have said categorically to us, our expert patients, we will not have a trip. You can only give us a 10 milligram. We will not countenance losing control. We're only going to take 10 milligrams of psilocybin. That's the most we're going to do. And then we're going to see if that helps you. And if we tolerate that, then maybe next time. So, the purists say that's not going to work, is it? You've got to blow their minds apart to get them over their OCD. And I say, but the reality is, you've got to take this step by step. And I have, interestingly, so I've worked in the field of anxiety disorders most of my professional life. I would quite often see patients who had come out of the Maudsley Hospital, who'd been part of the original flooding experiments. You remember flooding? You put someone in a claustrophobia, you lock them in the coffin for 6 hours, and then their claustrophobia is gone. Well, quite often it isn't. And quite often they never recover. And quite often they would come, well, not often, but certainly there are cases, they come to find other therapies for their failed flooding. And I don't want psychedelics to end up with a kind of legacy of negative press that flooding had.
Yeah, right. So I guess if we were to think about, like with any innovation, we've got, I think with technology, they often talk about this innovation graph, the innovation trigger, the peak of inflated expectations. Then we've got the trough of disillusionment, the slope of enlightenment, and the plateau of productivity. Where would you put psychedelics on that graph for, currently? Where would you put it?
So that's a really lovely question. So in my research, we're definitely on the upward curve. If you look at investors, they're way ahead. There's an absurd amount of hype about psychedelic therapy. All the money that in the States and Canada that has been made out of the cannabis, the boom is now moving. So, I'm kind of hesitant about this massive enthusiasm for psychedelics as a way of making money, but I think certainly we're on the rising phase of them as being a therapy.
Right. Yeah. You mentioned cost as a big barrier. So, what could you give us an idea about?
Oh, hang on a sec, Samuel. It's not going to be a barrier to a rich country like Australia. No, it's only a barrier in Britain. I mean, that's the problem. Only poor countries will struggle.
Yeah. But I guess you wonder whether the PBS is going to sort of fund it. I think we're a while away from that. But in terms of, it sounds quite cost intensive, but would it be sort of similar to someone having a ketamine infusion? Because when you sort of described it, it sort of sounded...
Oh, it could be cheaper than that. I mean, because as I understand it, ketamine, S-ketamine is licensed for sort of twice weekly treatment for 4 weeks, isn't it? And then, so if you total up all those treatments, it'll be cheaper than that.
Right. So fast forward...
You're only potentially, it's basically it's one big therapy day. It's psychotherapy sort of before and after. So if you total it up, maybe it's sort of 40 hours of therapy engagement plus a room and a drug for one day.
Wow.
But that's a lot more expensive than a dollar a week at $1 for.
Yes, absolutely. I guess compared to the antidepressant, clearly there's a cost differential, but when it comes to some of the neurotreatments, possibly not. TMS, I guess, S-ketamine, possibly.
Oh, I don't think it'll be much more. Yeah, as I say, I think it might be cheaper than it, but it's certainly in the same range as those innovative treatments.
Right. So if I had to, if we had to sort of predict or foresee, when do you think psychiatrists potentially might be in the position of actually prescribing psychedelic psychotherapy?
Well, that'll be quite soon. The bigger challenge is going to be what the challenge we have met in your country and in my country with medical cannabis. It's not that the drug, it's not the medicines work, but doctors won't prescribe because doctors aren't educated. Doctors don't like the idea that these things have come up in a different way from patients often. So the limitation is going to be doctor education, which actually I think is why this interview you've just done is spectacular, because we've gone through everything, all the issues that doctors confront me with when they're trying to find reasons not to think positively about this treatment. But it's medical education and psychologists. I think even I think psychiatrists are probably going to be more open-minded. But as you know, psychologists often get stuck into therapeutic ruts, the big battle between CBT therapists and behavior therapists. It's the same thing, but they spent 30 years arguing with it. We need to get psychologists interested because optimizing the psychology is going to be harder than optimizing the pharmacology. We've kind of optimized that already now. So we need psychologists optimizing the therapeutic interventions that they give.
Okay, so I guess we're coming to the end of the interview. This has been absolutely fascinating. I'd like to sort of end with, what would be your 3 most important points? Of course, you can give us more, but what would be the 3 most important take-home messages for psychiatrists and mental health professionals when it comes to, psychedelic psychotherapy or psychedelics in psychiatry?
Well, the first is that certainly psilocybin and MDMA are going to be proven therapies in psychiatry within a few years. That's the first point. The second point is, I believe they're going to revolutionize many aspects of psychiatry. And I hope psychiatry will embrace them. Because if it doesn't, then we're going to go through this period of maybe years, maybe decades, where patients suffer. Let me give you a little sum I've done, a little bit of arithmetic. Before LSD was banned in 1967 in America, the US government had funded 6 trials of LSD, 1 or 2 doses, for alcoholism. Recently, some Norwegians reviewed the meta-analysis of that data, and they came up with an effect size of 1. So it's twice, it's 2.5 times that of acamprosate. So this is the biggest effect size ever seen in alcoholism. Now, in the 50-odd years that these drugs have been banned, I've estimated that over 100 million people worldwide have died prematurely from alcohol misuse. If LSD only helped 10% of them, that's 10 million lives premature death saved. That's the kind of number that psychiatrists should be thinking about. The opportunities for these drugs to change the whole life trajectory of patients is enormous, but it won't happen unless psychiatrists get interested in it and at least try it out.
Yeah, and I think, Professor Nutt, you've always sort of thought outside the box and led a lot of this research for a very, very long time, and have been outspoken, mainly because you think about the benefits of these treatments for patients, and I guess you're walking the talk by being involved in this research as well, so seeing actually firsthand evidence as well. So yeah, I really hope that this is something that we can actually utilize to improve lives, because it clearly sounds extremely promising.
Thank you very much, and that has been a great interview, rigorous, but all to the point. Thank you very much indeed.
Thank you very much, Professor Nutt, for joining us. Have a good morning, and take care. And stay safe, most importantly. Hope to see you in Australia sometime in the future. I'm sure you'll agree that was a really, really fascinating interview, Professor David Nutt. I guess we're all hoping that in the future, as psychiatrists and mental health professionals who are able to prescribe, that we will be able to utilize what seems to be something really, really promising in the landscape of new treatments, and most importantly, treatments that with 1 or 2 sessions can potentially have some enduring change for patients. So with that, take care, stay safe, and I hope to see you on another edition of Hub Bites.